All right, let's go ahead and let's get right to it. I'm going to go ahead and record this. And I also wanted to let you know that I'll shut off the recording towards the end. So if you wanted to stay on and ask further questions that maybe, you're not comfortable asking in a recorded kind of platform, I just wanted to also provide that option as well. All right, so let's go ahead and start. The first thing I have that I wanted to get to is any logistical questions and administrative questions on grades, on, obviously the final format, whatever it might be. We have extra credit, any of that. Any questions?
Hi, Professor. I know I emailed you. I just am still a little bit confused about the extra credit.
Sure.
And so I think maybe saying it out loud will help clarify. So I never did the podcast when you first said that we could do it for extra credit. And then you came out with the second extra credit, which was the 3 options. So I've already done the second extra credit. I'm just now trying to clarify if it's one or the other, or if it's 2 separate extra credit opportunities.
Awesome. Thanks for the question. And that's our job as professors, is to screw everything up and to confuse you guys, right? I mean, that's what we're here for. And so hopefully I don't screw you up too much when it comes to, the order and what we're doing with all this. But what I wanted to do is provide you guys with more opportunities. And so fundamentally, there's two opportunities for extra credit in this course, one of which I assigned a while back, right? And the due date was a while back. I actually changed it. Now it's due, I think, the 18th now, if I'm correct on that. Yeah. So the podcast was the first one. Okay, you can do that one. The second one, so I changed the due date. I wanted to extend that for students that might need or want that opportunity. The second one that I just published here, I can't really recall when, is general extra credit. And within that's in Unit 3. If you click on the tab, in that specific one, you have 3 options. So you have the ability to decide which one you want to do. And I can't recall, I think there's 2 articles. So option 1 and 2 are specific articles that have been written, and then you do a review from there. And then the third option, if you don't like those 2, then you can come down to the third one. I think that's a basic synopsis of what you've learned in the class. That would be the third one. But basically, out of those 3, you choose one. So at the end of the class, if you exhaust extra credit, you're going to be turning in 2. Okay. Does that make a little bit more sense?
Yeah, it does. Definitely.
Okay. Yeah. Hopefully that does. And so there's 2 opportunities. And then just the second opportunity within that, I give you 3 options. So it's a menu of which you can pick one out of the 3. Okay.
Awesome. Thank you.
All right. Yeah, no problem. Thank you. And like I said, if anybody else wants any questions that might not be on the call, you can, email me or message me, and we'll go from there. Let's go ahead and get to it. Let me share my screen. And what we have here is this. All right. And can you guys see the study guide? I just want to make sure, because I don't want to waste all my time and then it's not even up there. You should see right now the chapter 12, clinical psychology, psych disorder study guide. So that should be on your screen right now. Okay. And so the agenda that I'm going through here is I'm going to cover the first 3. And then I'm going to pull up the slides on the actual disorders that you're going to be tested on, because there's so much information, and I want to make sure that I'm covering the things that you need. And so I don't want to just, throw a bunch of stuff out there. Let me make this point here, that for those that are on this call, and then for those that are not, I got to tell you, this study guide that I have given you is exactly from the test. Exactly. So this is not just content that I'm throwing up here and covering. 1 through 13 on this review, these areas, there's variety. There's 3 to 6 questions that come from each area. So I just want to be clear that this study guide is really targeting the specific questions. I know I've gotten some feedback one of which was like, don't list just all the content areas on the study guide, and I don't do that. Okay, so that's not, definitely don't do that. It's the specific areas that I want you to focus on for this actual exam. So I wanted to be clear with that. And then once I continue, I'll show you specifically a couple strategies on how to attack this final exam. So number one, and again, the assumption that is you've already studied and you have familiarized yourself with the specific content in this area. My job is just to provide you with a little bit right here that might initiate curiosity and a question to dive deeper. Otherwise, it's just another lecture. Okay, so let's go ahead and continue. So out of the gate, clinical psychology, you're going to have questions that are going to be asking you the criteria of how we go about diagnosing mental disorders. And that criteria is this, is that when we get to a level of mental disorders, that they have to be deviant, maladaptive, and distressful. Okay. Now the questions are going to be specific to this, to those three areas. And what's not up here is that it has to be over a long period of time. Okay, that's critical in order to be able to diagnose mental disorders. And it doesn't necessarily have to be just one of these, just distressful or just maladaptive. It could be one, it could be two or three. Many times it's usually two or three, but sometimes we see one. So that's the criteria. You're going to have questions for that. Now, the questions are going to be what questions? They're going to ask you specifically, like, what is deviant behavior, right? And so that could be a question. And then you could also have scenario-based questions. You know, such and such goes to the store, they do this. They have this feeling or this symptom, and then you would need to match that with that scenario. So that's the gist of the test, right? So it's either not definitions, but it's more conceptual questions as to like what this is that we're talking about. It could be that, or it could be scenario-based. So deviant, and again, let me know if you have any questions. I'll go as deep as you want, and I have no problem with that. But sometimes we get confused with a couple of these, so I'll dive just a little bit here. Deviant is atypical statistically. Okay, that means behavior is away from the average within the cultural context. Okay, so there's average, there's a bell-shaped curve of our behavior. You know, when it's winter, most of us put on, you know, warm clothes. So if you're really far from that average and you're wearing shorts and no shirt or a tank top or whatever it is in the winter and it's 30 below, you know, that's deviant. That's atypical statistically. And then maladaptive is really dysfunctional. It's where the individual has a hard time coping with their environment to adjust. Distressful is what it is. That's pretty intuitive, but again, I can go deeper on that. All right. And then what I can do, and I'll just ask right now, is there any questions on number one? And if not, I will stop the recording towards the end, and you can ask any questions without being recorded. So it's totally your call. Is there any questions on number one?
No, no questions.
Okay, very good. Okay, not to say that's good. I mean, the questions are the way to go. So you can drive this whole thing. If you have questions on 1 through 13, that would be the way to go because I'm meeting your needs. Okay. Number two is you're going to get questions certainly on, like, where do these mental disorders come from? You know, how do they progress? How do they manifest? And how do they develop over a long period of time? And that is when we get into the approaches of clinical psychology and psychological disorders. Biological approach is you need to know, you're going to have questions on, you know, internal organic. That's biological. So individuals of this camp describe pathology and psychological disorders as one that is organic, maybe someone's born with, or that has manifested in the brain. And the area of emphasis here that the test will cover is neurotransmitters. There's something going on there. It could be brain structure or function. And like I said, when I'm covering these, if you have questions, you know, let me know on these specifics. Also genetic, predisposition or just genetic component to that. That's biological approach. There could be other professionals that say, wait a minute, there's more psychological component to psychopathology, which means that it's learned or it's manifested by way of experience. And the emphasis is thoughts, emotions, and personality when it comes to psychological approach. And then social cultural is really looking at the social context that we're working with, looking at customs, social groups, looking at culture, norms, looking at socioeconomic background, for example, poor individuals or individuals that come from a low economic status, that that would actually predict obviously a little bit more pathology. So that's that approach. And then the last one is biopsychosocial, and that is pretty much what it says right here. It's the link between all of them: biological, psychological, and social. And the test does cover where there's not when we look at that approach right there, we don't look at one component standalone in isolation. So we're not going to look at a psychological disorder at just from a biological lens. If you're coming from the biopsychosocial camp, you're looking at it from more of a threaded, holistic approach. So that's what that means. Okay. Any questions on number 2? Okay. We'll get to number 3. And like I said, I will stop this at the end if you have any questions. And so criticisms of the DSM. First of all, to attack this test and looking at this chapter review and the previous chapters with the study guide, if I put something down like criticisms of the DSM-5, first of all, you should know what the DSM-5 is in general. You should know what that is. If not, read about it. Go back. I have lecture videos on those things. Also look at not just criticisms, but look at the strengths, the good part of the DSM, because there's many of those. You will have some questions from that. No, let me go back on that. You won't have questions on what I just said, but in order to answer the questions, you do need to know those strengths of the DSM, like what the DSM is, diagnostic to statistical manual, 5th revision. You should know that it's a really large manual that lists all the psychological disorders and their symptoms, and statistically their prognosis and their development. And so, I'm not going to review all these unless you want me to. I have no problem doing any of that. This is in the textbook. My job, as I've done with lecture videos, is to expand what the textbook says. And I do try to align with the textbook. Otherwise, could lead to a lot of confusion. And so there's a lot of criticisms. In fact, I think the book and King, our author, distinguishes between 6 of them. And just some of the top ones you'll be tested on. One of them is the biggest criticism is that the DSM-5, and that's, again, a manual with how clinicians go about diagnosing psychiatric and psychological disorders. One of the biggest criticisms is that it looks at psychological disorders as medical illnesses. And so the implication of that is that, well, psychological disorders all have a biological cause, and that's simply not the truth, but really the research does not suggest that. So there's multi-factors when it comes to clinical psychology. So that's a major criticism. Some of the others are there's a social norm component and a personal bias and personal subjectivity with clinicians, where it's kind of a grab bag of clusters of symptoms, and that can cause some subjectivity when it comes to maybe overdiagnosing or just diagnosing in and of itself. Another criticism, and these are I'm not just just saying these, but these are the ones that you should know for the test to be able to answer questions. The next one is the DSM does overemphasize symptoms and problems, and that leads to problems. That leads to what we call stigmas, where individuals are hesitant to go see a licensed professional in this field because of the ramifications of the stigma of labels. And so that is a problem as well. And then there's some others, such as there's been some additions to psychological disorders in the manual over the years with less research devoted to those. And so that could be a problem, because we don't have a substantial amount of research that's reliable, then that leads to over diagnoses. And then another one is we already have disorders that are in the manual right now that have been lowered with their standards, such as, what's one? Attention deficit or hyperactivity disorder. So ADHD is one of which that some of the standards have been kind of really adjusted over the years. And what's happened is that the actual diagnosis rate has gone up substantially. Not to say that male practitioners are off with this, but we just need to get really clear on the research and have a kind of a common thread when it comes to communicating those. And then the last one is, I think I got to 6. And the last one is is really there's no causality. So the manual just lists symptoms and prognosis, the progression as to how it will develop later on, but it doesn't really get into any particular causes. So that leads mental professionals up to interpretation, and that comes back to that subjectivity. So that is the three that I wanted to cover in a little bit of detail right there. And what I'll do here in just a second is I'm going to flip and switch to this, just a list of these disorders that you're going to be tested on. And so with that, is there any questions on number 3? Okay. If not, then I will share something else. This right here. So you should see the actual slides. Can you guys see the slides? All right. Could someone let me know, just so I know I'm not recording something that's not really there when I'm talking about it?
I can see
Is that okay? Thank you. I appreciate you. Thank you. So, all right, now I'm going to go down in order here. Like I said, I'm not going to re-lecture. I am totally here for you. So if you want me to, I can do it. If you want me to look at a specific area of this, that's what I'm really here for, is to really tie up loose ends at this stage. In terms of what you know, what you don't know. When we look at general anxiety disorder, you're going to have, questions again, and I'm going to talk about that in a little bit in the next slide. I think it's coming in the next slide, but you're going to have what questions, such as like, what is anxiety? What is generalized anxiety disorder? And I'm not going to ask you just a question such as list out symptoms, but you need to familiarize yourself with what general anxiety disorder is. Like, how would you define it? It's a negative emotional state characterized by nervousness, worry, apprehension, right? And then there's some other details. There's a somatic component, and then there is a cognitive component. So I won't get into all that, but those are some things, you want to be able to define it and understand it in your own words so that you can apply it. And then do know, like, for example, the persistent, the diagnosis for this means that it's over a long period of time, such as 6 months. Okay. And then the big thing with GAD, so generalized anxiety disorder, is that there's an inability to specify reasons why. That's big. You will get questions that they're scenario based. Jack or Julie is walking to the park, and all of a sudden their heart starts to thump and they feel really nervous, anxious, and they weren't really clear as to why when they were asked. Well, that goes right to this, meaning that there's no really specific reason. If I put in an answer in there that maybe says something like a speech, is it because of the speech? Well, not really the speech. If you're nervous because of a speech, we would not align that with this disorder because that doesn't fit the criteria, right? So hopefully that helps you in terms of the questions for the exam and then how to study it. So we're really looking at how, like, what is a disorder, and then what are the scenarios that you can see coming from that. That's what we're looking at. The next thing when it comes to these, I don't know how many I have on there, with chapter 12 is the psychological disorders that I have listed on there, is there's really 2 parts you want to know. Okay. Is like I just said, what, like, how would you define it? How would you define what generalized anxiety is? The second part is, so be able to understand that, right? Don't just read over it, your definitions, be able to study it. That means recall it in your own head, be able to rehearse it in your own head, not just exposing yourself by reading it and seeing it. Try to see it in your head and practice it in your head. That's the first part. Secondly, is what's called etiology. That's the cause of the disorder. So the etiological component of mental disorders are, one of which biological, it could be psychological and or sociocultural. So you want to be aware of that as well. For example, right here with GAD, with this disorder, we have biological factors right here, and then psychological and sociocultural, some of which they go together. Okay, so those are things you want to know for your questions. And then again, like I said, I'm not going to go over all this. I do know students sometimes have questions with like GABA deficiency. What does that mean? Well, that goes back to chapter 2. That's a neurotransmitter. So when we look at the question, hey, what causes generalized anxiety disorder? First of all, it's multi-layered, multifactorial. There's a lot, but there's one that shows up consistently with a lot of individuals, and that's GABA aminobutyric acid deficiency. And again, not to get too detailed here, but chapter 2 we talk about GABA, meaning that that's the neurotransmitter that sits in that synapse, that gap between neurons, and inhibits the binding of the neurotransmitter to the other side of the gap, which means it slows down activity. So it's an inhibitory neurotransmitter that slows down activity. And so if there's a low amount of GABA, that means that we might see more of an active central nervous system. And that does help explain, the generalized anxiety component. So I do want to cover that. And then, like I said, if any of these down here don't make sense, observational learning, these are more intuitive. One that students have questions on is this right here, internal sensations. They misinterpret. For example, individuals that are diagnosed with this disorder, many times they misinterpret sensations. And so their body starts to change. Maybe their hands are shaking, or they lose some of their breath and they're just kind of choking a little bit. But that maybe they're walking up a flight of stairs, and even that, if they can't breathe or their body starts to change, they misinterpret that and label it as anxiety. And so that's what we're talking about there. That's called cognitive appraisal. And so individuals that have this disorder, they're very sensitive to the internal sensations, and they also a lot of times misinterpret those as over-indexing on general anxiety disorder. Okay. All right. So if there's no questions with that, I will go ahead and continue here. And this is a specific example of a question. By the way, this comes right from your test. So if you guys get this wrong, I'm coming at you. Right? Because this is a question that I pulled right from your final exam. And I don't usually do that, but I do want to be able to show you like how to attack this. And so the first thing is how do I study for this exam? We talked about critical thinking, and critical thinking, like what is that? Hopefully you have learned that throughout the whole semester as a psychology student. Social science of psychology is one that lends itself to the scientific method and being a critical thinker. So critical thinking is thinking deeply and actively towards something, challenging your assumptions. So what you do as a critical thinker for an exam is first and foremost is to read the question. Now that might sound like intuitive, but that might not be the way for you to do it first. You can either read the question critically first. That means read it a couple times. You read the question, then you try to recall in your head before even looking at the answers. Okay, so you don't get distracted. Read the question in your head, for example, like this. James, a student has been experiencing persistent anxiety. Right there. That's a question on anxiety disorder. So what do you know about that in your head? Start thinking about that a little bit. Then you come to the answers and you see where it fits. Okay, that could be a way. Or as a critical thinker, you're going to think deeply and actively. You might look at the answers first, such as instead of reading the question, you might read the answer. You might read generalized anxiety disorder. Oh, okay. What do I know about that? Just do a quick hit, 20 seconds in your head. Panic disorder. What do I know about that? Same thing right here, specific phobias, on and on. And then come back up here and read the question. Okay? So that's what we're talking about right here. Now, to get to the nuts and bolts of this question, again, I do not want to teach you how to take a test. Like, you can be really good at taking tests, and that does not mean that you learn the subject well. Critical thinkers, they learn the subject well, and they might still get a B on a test. They might still get a C on a test because these are not easy questions, right? So critical thinkers, they're looking at the totality of the question. So let me give an example. Here it is right here. A student has been experiencing persistent anxiety, constant nervousness for at least 8 months. Okay, let's see. Oh, hope everybody's still. I just got something. Hopefully that doesn't kick you off. But right there, 8 months. There you go. Ding, ding, ding. We know we just covered generalized anxiety was at least for 6 months, right? So there's that deal right there. Critical thinkers looking for the hooks, looking for parts of the question that align with whatever the answer might be. Let's continue. He has been constantly worried about his relationships and health. When asked for the reason why, that's that etiology, right? For his anxiety, he's unable to specify. Right there, we go to generalized anxiety disorder because that's one of the causes is that they're not able to really specify. It just kind of happens, right? It just happens. And so that is where we go with this. Now, if you get to some that are similar, such as general anxiety disorder, if you get some answers that are similar, I can't even see the bottom one. Something, it's not showing me the bottom. But if they're similar, I think that's social anxiety disorder, then you need to really go back and read that question, be critical, and pull apart some of the details, because general anxiety is not the same as social anxiety disorder. If we had social anxiety disorder, there would be something about humiliation. There would be something about really concerned about shame of others and embarrassment. That would be in there. And you certainly wouldn't have this right here. He is unable to specify. So if it was any of these three right here, you would be able to specify that, right? So that is part of the question right here. So he is unable to specify. Just reading that slowly, critically, goes right to the top one. So you automatically eliminate the other ones. So hopefully that makes a little bit of sense. And again, I mean, let's make no mistake about it. Some of these questions, they're hard. Like, don't be hard on yourself. If you're getting, not a lot of these hard questions correct, it's not easy. If you get an A in an exam, that means you're excellent. You know the subject extremely well. Okay. I mean, sometimes I think we misinterpret like what an A really is. That means like you are an excellent learner and understander of some of this content. And this is just a test. That means you're excellent at maybe taking this test. And so don't put all those eggs in one basket. And the next thing is, not every question's like this. So the last thing I'll say on mechanics of the test is, this is a scenario-based question. This is one of the hardest ones that you'll see right here. And so I just showed you how to attack that. The second kind of a question you'll get is more of like, not a definition, but really explaining what something is. And so you need to know the definition to be able to articulate and pick the right answer. Okay, so that should make sense. And let's go ahead and continue right here. If you have any questions, let me know. Panic disorder, we're going to cover, again, some questions definitely right here. Not going to cover all this. I will cover this. In your tests, we want to pull apart, and here's critical thinking too. And we learned this again in chapter 1, is to be able to compare and contrast. And critical thinkers, they're pulling apart like what's fact and what's fiction. And that's just the essence of taking a test like this. You're trying to get to the truth. And so that's critical. Now with panic disorder, we want to distinguish between a panic disorder and a panic attack. A panic attack happens because of a specific reason. If you're on the edge of a cliff and you feel you're losing your stability, you might have a panic attack. You might feel like you're having a heart attack. To compare that with a panic disorder doesn't really come with cause. Like, it can come out of nowhere. You can feel like you have a heart attack, and that's the symptoms, is shortness of breath, chest pains. And so right there, just understanding the difference between those two will help you address some of the questions in the exam. And then the etiology, most of these are intuitive, but I do want to cover this. Our textbook doesn't really cover in detail some of these things, such as, it's not necessarily just norepinephrine that impacts that could progress with panic disorder, but it's what's called brain lactate, increase in brain lactate, that can initiate the release of norepinephrine in the brain and throughout the body, in the bloodstream. So I want to be clear with that. And then we have GABA. We've already talked about GABA, neurotransmitter serotonin. The last thing here that some students have questions on is CO2. This is more psychological, which is classical conditioning, back to chapter 5. And again, the more you can relate all this stuff to previous chapters or chapters that you might learn in other classes, the better, the deepening your memory will be, because that goes to the memory chapter on processing information. You want to go as deep as you can. And how you go deep is to apply it to other things that you've learned in your life and in this class and in other classes. So chapter 5 right here with conditioning comes to this, is CO2. When we lose oxygen, carbon dioxide, we don't have oxygen. Let's say you're walking up a flight of stairs and you feel like, man, I can't breathe that well. I feel like I'm losing my breath. Well, if you have panic disorder, if you have been diagnosed, what happens is those individuals, they take that cue, that CO2, that lack of oxygen, that's the neutral stimulus. They take that as panic. And so they pair it with panic, and then it leads to a conditioned response, which is a full-blown panic attack. And so that goes again back to chapter 5 on classical conditioning. That's that link with CO2. So that's been shown to come up with individuals as well as instrumental conditioning. That's back to chapter 5 as well. So I wanted to make sure we're clear on that. If there's any questions, just go ahead and let me know. You also have the chat box. I'll look at that at the end. And again, I will stop the recording to address any questions. All right. Specific phobias, you will have questions on this. Again, scenario-based questions. How can you get better at scenario-based questions? Well, one of them is, for this specific one, specific phobias, is to know the difference between an actual phobia and just a fear. Okay. Being fearful of a snake does not mean it's a phobia. Fear is rational. It's highly adaptive. It makes sense. It's what allows us to pivot and adjust to our everyday environment. Developing a phobia is totally irrational. Okay. The difference between this is now the irrational component is you're overwhelmed and you see a snake on campus. I actually have a funny story about this. I won't get into, but it's really funny. But here's an example. If you're, let's say that you see a snake on campus, and I have seen a snake on campus, then your heart might jump up to your throat, and you might have that fight or flight effect that activates sympathetic nervous system. That makes sense. That's fear. That's adaptive. But if someone starts to develop a phobia, what happens is now you're not even going to come to campus ever again. You might even drop out of college because you're so afraid of a snake showing up excuse me, on campus that you're not going to go. And again, statistically, the likelihood of that happening is not high. And so that's irrational. So that is how just know that right there, because that's going to, play a role with some of those scenario-based questions. And then of course, just know the what. A phobia is irrational. It's overwhelming. It's persistent, which means over a long period of time. Fear of an object or situation. And then the etiology is pretty self-explanatory. One thing that's not in here though is, let's see, learn. Okay, is just, again, you think back to chapter 5, classical conditioning. Remember how I talked about little Albert and the whole infamous study on little Albert and how they, classical conditioning, how the individual banged that big old, metal rod, boom. And then Albert, got really scared, and they presented the neutral stimulus, and all of a sudden, and then we have a conditioned response, which was fear. So a big part of fear and a big part of really social phobias, or any phobias, I didn't mean to say social phobias, I meant to say phobias in general. The whole aim there is also where it comes from, is classical conditioning. Back to chapter 5. Okay, let's go ahead and continue. Like I said, I can always go back if you have any questions, whatever it is you need, I'm here. Social anxiety disorder is, again, an irrational. Also, this is also called social phobia. We just talked about phobia, so it's irrational. Intense fear of being humiliated and embarrassed in social situations. And so most of us are highly adaptive in social situations, and we still feel embarrassed at times. We feel hesitant to eat food or to talk when we're in groups. That totally makes sense. Some people, not as much as others. When it comes to a clinical disorder, that is when two things occur. One, again, this helps you answer those scenario-based questions. Two things that occur. One is the individual doesn't even go to the social gathering because they're so fearful of being humiliated or found out. They're going to see me nervous. They know that I'm nervous, how I'm holding my glass, how I'm talking, how I'm breathing. They're going to notice that. So you don't even go. That's a problem, right? Because that's that maladaptive criteria. That's dysfunctional. We can't function because we can't adjust to that. That could be one area. The second one is maybe the person goes to social function, but they're really not themselves. If they're just kind of, patchy, they overthink how they're supposed to present themselves in their head. They make mistakes. And so a lot of times, through that self-fulfilling prophecy theory that we talked about earlier in the class, at least someone tripping over something or saying something, not because it's some airy-fairy magical thinking, because they've practiced it in their head so many times that they're more prone to do that. All right, and then etiology, the causes, there's many. Most of this is intuitive. However, one of them might not be, which is called neurocircuitry. What that means is brain structure and function. Individuals with social anxiety disorder have highly sensitive sensory input coming in. So once it reaches the brain, so I see something, it comes in that I see as a threat. I go to a social gathering, someone's looking at me, and it immediately goes to the thalamus. It's rooted to the occipital lobe. Bam, goes right back to the amygdala, to where now it starts to discriminate between threat, between foe or friend, and many other things. Again, I'm reducing it down, but that's what happens, is that those areas of the brain are highly sensitive. The thalamus, the amygdala, and then the amygdala, the neurocircuitry, the action potentials work their way up to the frontal lobes. The frontal lobes is what helps inhibit some of the drama, we would say. So if someone's looking at me and I'm eating and there's a lot of people around me and I might be talking, someone with social anxiety is so sensitive and hypervigilant, they can pick up on the smallest cues, like facial expressions. They can pick up on so many things that other people can't. They're playing mental ninja, and they can pick up on so many cues where they can't inhibit it though. Their frontal lobes have less activity, so they're not able to tamp down and say, no big deal, I'm going to do whatever I do. They don't do that. They continue to feed on that, and so it's a cycle, that leads to problems. So neurocircuitry means sensitivity in thalamus, amygdala, frontal lobes. All right, let's continue. OCD is pretty much what it says in the title, is individuals that have obsessive thoughts and compulsive behaviors. And so understanding this is pretty nuanced, but really the psychologists define obsession and compulsion differently than lay people do. Obsession or obsessiveness is intrusive and unwanted thoughts. Compulsive behavior is where the individuals feel compelled to behave and basically execute a irrational, ritualistic behavior or mental action because of the obsessive thoughts. Okay, and so an example would be some people that are afraid in their head. They're mentally thinking about, I don't want to get sick. They're what we call a germaphobe. So they're going to wash their hands, but not like all of us wash their hands. They wash their hands hundreds and hundreds and hundreds of times a day. I mean, so much that they have to go to the hospital that they might cut their hands down to the bone. And it's really bad. And so the difference here between OCD and maybe someone who's really tidy and organized, they might not be clinically diagnosed. The difference is the intrusive, unwanted thoughts. And that's a big part of what distinguishes, where clinical OCD parts ways with just orderly over here and tidiness. Okay. And then, of course, we have cleansing and counting. There's also mental actions. Individuals perform mental actions in their head. And basically, OCD, think about this to answer some of those what questions and scenario-based questions, is about reducing anxiety. Okay. Remember the ego with Freud, the id, the ego, superego. The ego is really there to mitigate and to lower anxiety that's caused between the id and the superego. With OCD, it's the compulsive behavior that's there to lower the anxiety because of the intrusive thoughts. But obviously the problem is that it serves to reinforce the disorder. So it can lower anxiety. People can feel better about themselves, but it's hurting them physically. And the biggest part is maladaptive. It's really hard for them to function. Okay, so let's see. Most of this is pretty self-explanatory. Okay, life stress, all this. Again, let me know if you have any questions. PTSD, post-traumatic stress disorder, is one where the individual is exposed directly or indirectly to a traumatic event. Okay, and they there's a overwhelmingness to it to where they can't cope and adjust to the stress. And that is essentially at the center of it. With PTSD is most of us, let me go back on that. We all will or have experienced trauma. We will. And we all bounce pretty quick. We all adjust and cope actually very well when it comes to it. Now, some people don't, and the situation, the severity, the proximity, how close you are to it does play a role. Some people don't. And when they feel overwhelmed with the ability to adjust and cope with it, that is where they run the risk of developing this disorder. And so we see flashbacks, individuals that have been a part of, war or sexual traumatic event early in childhood, or even as they're an adult, maybe they got mugged, which is an oppressive situation, or there's a natural disaster, 9/11, such as that, or earthquake, anything like that could lead to this. Now, I'll go right to this for the test. So looking at the causes, there's a lot, again, there's a lot of stuff here, but two of which you need to pay attention to is the APA axis. I talked about this in the lecture a while back, but essentially what it is heightened stress response, which is a heightened fight or flight response, sympathetic response. Hypothalamus, pituitary gland, the adrenal gland working together to help activate the body into fight mode. That could be a problem. So here's an example. If someone's well adjusted and they're healthy mentally, they might wake up with a heartbeat of 50 to 70, somewhere around there. Someone who has been exposed to trauma that has PTSD, their sympathetic nervous system's on overdrive. So their heart rate could be resting in the morning, could be at 90 to 120, most days. And that's resting. And so that's an example of this. They're overactivated. So that's one. The second one is classical conditioning with operant conditioning. And so classical conditioning, chapter 5, neutral stimulus paired with another stimulus that leads to a conditioned response. When someone sees a threat, they can remember the smells, they can remember, the vision, the visual input. It's all there because of the process of classical conditioning. That again goes back to chapter 5. And then instrumental conditioning is reinforcement, is that people think about it in their heads thousands of times. So they reinforce it in their head thousands of times. So they have flashbacks, and there's so much going on here, but it comes back to the biological component of the HPA axis, and then the psychological component of classical and operant conditioning. All right, and then major depressive disorder, MDD right here. Let's see where we're at. I think we're getting pretty close. This one right here is when we see significant depressive episodes. Again, I'm not going to just read all this. What I want to tell you is this for the test, is that, like, what does that mean, depressive episodes? So we're really looking at, it's tough, but, there's a lot of pain when it comes to depression. So we're looking at fatigue. We're looking at lethargy, being really tired, amotivation, so not motivated. And here's a big one. This is a really big one right here, is helplessness. Helplessness, which means there's a sense of no control. We throw our hands up, helplessness, learned helplessness. Martin Seligman behind the research right there. So this is a really bad disorder. And you also want to know for your test that this is, to be able to be diagnosed with this has to be, these symptoms need to be shown. Amotivation, really, being fatigued, changes in sleep, changes in motivation, changes in the way you eat, what you eat. Do you eat too much? Do you not eat at all in the last 2 weeks on most days? And so anxiety is 6 months. Depression and depressive disorder type of symptoms is 2 weeks. It's really bad. And so this is highly biological, not to say that psychological components don't play a role, because they do. They play a big role. But we do see a strong genetic component to it. There's many things here. We see neurotransmitter serotonin that are implicated. We see norepinephrine. Now, one thing with neurotransmitters with this disorder is that it's not necessarily low or high transmitters, it's receptor cells. They have a hard time binding For example, serotonin is having a hard time binding to the other cell, which initiates the next action potential. So it's basically trying to put your key in a lock, but it's not really working. So that's that one right there. And then, the other ones are pretty intuitive. And so you'll get questions again. To come back to this, I need you to think about how to study for this is to be mindful of what the disorder is. Could you paraphrase it in your head, the definition and kind of how it works? That's that what. Secondly, where does it come from? Ideological. Is it biological? And most of them have a little bit of each. Some of them have more than others, but is it biological, psychological, social, cultural? All right, almost there. Bipolar. Bipolar is similar. In fact, I'm not going to say that. It is, but I don't want to, mislead individuals. Bipolar is characterized by extreme mood swings, very similar to depressive disorders. This one's much different in that someone can be really low and down for a number of days, but yet, bam, can come up to what's called a mania state. And so we see fluctuations in mood states. And that's why, so unipolar depression is what we just talked about. Bipolar disorder is bi, which is up and down, or two, meaning one can have very low moods, and then all of a sudden it goes really high. So mania is extreme energy. It is somewhat of extreme confidence, where it could be erratic. Some people can do things that they really shouldn't be doing because they've distorted reality to an extent. They're too much. They're too anxious. They have a hard time talking. They talk so fast, and so it's pronounced. We can totally see the difference. Now, bipolar is one of those disorders that does have a strong biological cause. And so in PET scans, positron emission tomography, we look at metabolic activity. Remember, in our brain, every time we have an action potential, it demands glucose to provide energy to that transmission. So when we put someone who has bipolar disorder in a PET scan, we see that there's swings and rivers and valleys of glucose. There's a lot of glucose activity that just fluctuates up and down, and that makes a lot of sense when it comes to neuroscience of the brain and how it works. And then neurotransmitters right here. Okay, bipolar disorder. I think the last one here is schizophrenia, and schizophrenia is this is one of the psychiatric disorders where there's not a split with mood. There's not a split with personality. There is a split with reality. Okay, so we call that psychotic. Individuals that are diagnosed with schizophrenia are highly, severely disordered, and it's chronic over a lifetime, and they can get most of them are, they need inpatient health, and they can reduce symptomology with massive, not massive, but very strong psychiatric, psychoactive drugs. It's a tough disorder. And the reason why we cover it so much, the longer you stay in psychology, you'll cover schizophrenia for a long period of time. You'll have a question, why is it that we cover schizophrenia so much when it only represents 1 or 2% of the population? Very, very small numbers. The reason is because individuals get diagnosed very young, and they live for a while, and it costs the U.S. economy millions and millions of dollars for therapy, psychotherapy mixed in with inpatient care, and of course medication. And so what you want to know for your test is what is schizophrenia, and then a big part of that what is what we're going to talk about now, and then be able to understand the symptoms. Okay, especially with schizophrenia. I'm not going to ask with all the other disorders to just list a couple of the symptoms, but I will say this: with schizophrenia, we will be testing you on what's considered a positive symptom and what's considered a negative symptom. Positive is what it is that it's added. Now, like chapter 5 with operant conditioning, we talk about positive reinforcement, negative reinforcement. That is similar with this, meaning that positive symptoms for schizophrenia does not mean it's a good thing. Doesn't mean that at all. Positive symptoms mean they're just added. Okay, they're added to the behavior. So hallucinations, delusions, these are all added. Hallucinations is really false sensory input coming in based in the absence of real stimuli. So that's false perceptions. And then delusions is really false beliefs. Thought disorders, disorganized thoughts, disordered movements. So those are all considered actual positive symptoms. So you might get a question, what question? Like, what is considered a positive symptom? And then you have options to choose from. You can also get a question such as, Jack or Julie does this. They're thinking about someone that's going to blow up their house, right? Scenario-based questions, and then you get to choose from the actual, is it a positive symptom or negative symptom, and or the actual name of the symptom as an example. Okay, and then the negative symptom is taken away. So it doesn't mean it's a bad thing, even though they really are, they're not productive at all. Negative means that they're taken away from ordinary behavior. If you're mentally healthy, you're going to have these things, such as you're going to have social connectedness, you're going to have positive affect. But these individuals that have been diagnosed with schizophrenia, they don't have it. So they have what's called a flat affect. So mood is kind of stale. They have a hard time socializing. And then we have the cognitive symptoms, right? Okay, and then the last thing here that I want to cover that could be a little confusing, that's not as intuitive, is this one down here. Well, first of all, high concordance. This is a highly biological psychiatric disorder, okay, compared to some of the other ones that are more along the experience. Your environment that you're in can play a role. By the way, just because schizophrenia is highly biological does not mean that the environment doesn't impact it at all, because the environment can make it worse. It can increase the symptoms, the severity, and the intensity of the symptoms. But when we look at structural brain abnormalities, it says enlarged ventricles in the brain. Our textbook doesn't really cover much of what that means, but what that is essentially these holes that develop in the brain that start to fill with fluid. Okay. Now, hopefully that means something right now, because the brain does not operate. The brain is filled with matter, especially like gray matter, where there's a lot of neurotransmission going on. There's a reduction in that. And what that equates to is atrophy, is brain atrophy. And so we see that in brain scans of individuals with schizophrenia is just that, is brain atrophy, and that's represented through enlarged ventricles. So it's pronounced. We can see that. And then, same thing with neurotransmitters. And then psychologically, environmentally, there are stresses or stressors that can interact with all the things that we've talked about already with schizophrenia. Okay. All right, let me go here. Take this off. Back here. Let's see, screen sharing has stopped. Very good. I hope I stopped the screen. All right, let's bring this home here. Appreciate you and your time. Hopefully this helped. The last thing here, I got my little announcements here, is the final opens up on Wednesday, okay? And then it closes on Friday. So just, prepare yourself. I would recommend that you take some time and you get ready, get your environment ready. This is a 2-hour examination. And if you're fortunate enough to have a space where you're not going to have any distractions, you want to do that. You don't want to take it in groups. That's just going to distract you. Everything's shuffled too. So from my end, you want to do it by yourself. Eliminate the distractions. Give yourself as much time as possible. Read those questions as a critical thinker. Okay, looking for certain things, thinking deeply and actively. Whether you're reading the question first or the answers first, you can do either or, and then applying what you've learned. That takes place on Wednesday. I'm going to turn off the recorder here in just a second, but again, I want to say thank you, and I appreciate you. Some of these tests are not easy, and it's not lost on me that you're working hard. Some of you might have even been discouraged because you've been putting in so much time, and maybe you haven't seen the output. And I would say this: hey, stay in this thing. be discouraged, feel that pain. It should hurt. If you put in that much time and you're not yielding the results, yeah, it hurts, right? So then what are you going to do with that? So use that to drive your study habits, to maybe change some things. How are you taking in information, right? How are you processing the questions? Are you thinking critically, deeply, and actively? Are you slowing down? Not just looking for what looks right, but looking for what is right, comparing and contrasting. And then I understand that they're challenging, and that's why I have decided to provide a little bit more extra credit. And I also grade on the curve, okay? Which means I take a couple standard deviations from the top and I adjust it down. Okay. Now that doesn't mean that, hey, maybe I shouldn't perform well on the final. Definitely you need to do that because it's worth so many points. So either way, you need to step up, and you'll be able to. But I just want to let you know that I have tried to create as fair um, um, environment for you to learn as I possibly can. I do this because I want to. I don't need to. I'm financially secure. I love my job, and I'm really here for you. Um, I want to make sure that I'm here for you as a resource to allow you to learn, to develop those critical thinking skills so that you can move forward down the road and you can apply them. Even if you're not a psychology major, I totally understand that. So again, I tip my hat. I'm not wearing one, but I respect you. Stay in this thing. Continue to find ways to get better. And if you get discouraged, that's okay. Feel discouraged and use that as fuel to change the way you can approach it. And reach out to me, okay? Fill out the evaluation that I have. I don't have to do that. I want to do that. I want to get better. Fill that out so I can find ways to get better. But let me just tell you straight up, come to me, come to me, come to the person that can help you the most. So if you're going to complain, you should complain. You should be upset. I totally get that. I was a student. I'm a student right now. And complain to the right person. Come right to the source that's going to make the biggest change for you. So just kind of putting something out there to someone or some kind of whatever about something's not fair or something's bad, then I welcome that. Please bring that to me or your other professors. Go talk to them. This is about you. So complain to the right person. Go tell them, your thing, what's going on. Ask them, how can I better study? What are some study strategies and methods? We're going to help you as much as we can. So I wanted to end with that, and I'm going to stop the recording. And if you guys have any questions, we'll go from there. All right.